before I get there, are there any questions about any of these items? Does all that make sense, kind of what we looked at? Is that pretty clear from a measurement standpoint, where we sit at?
I think one of the things that I see by just looking at, and I think this is very good looking, or very good chart that we had to go by, the approach that was done for that. But I think, you know, this is going to go into what the recommendations are too. And I think by looking at this, it's not as bad off as some people have perception that it could have been. And I think that was one of the key things that we wanted to do is have a third party to come in, point things out. We know there's anything can improve, anything, but you know, and being the small rural hospital the size that we are, especially in the managed care, and I've seen some of that issues in previous work that I've done that it is difficult because it is, you know, the cost of doing business is it's relatively, you know, you go to the size and you've got a lot less or higher type situations based on your size. They're going to migrate more to your larger type situations and stuff. So I think this helps me looking at this, and I would hope, Ernie, I know you was on the committee and stuff, if there's anything that you could add to it or what you see.
Can't put me on the spot. I'm ready to let him go.
Yes, sir.
I've got one question, just clarification. I don't know if it was you or Cindy who mentioned earlier that you didn't look at quality. And I'm a little concerned why you didn't look at quality. I know it may not have a direct impact on cost, but my goodness, if you don't have good quality, it's got to have an indirect cost.
Sure.
And I'm just curious what your thoughts were on that. But I think we're high in quality.
You are. And a lot of, we need to focus in there from an operational perspective. Because the elements around quality are a lot more tactical and then also philosophical. But there is measurements about quality in the hospital. It is measuring quality, and a lot of the scores were very, very good. So we felt like from a priority aspect, there was a need to do a lot of focus. And secondarily, from a desktop perspective, quality is hard to actually desktop. I can look at your data and say, well, here's where you sit, but really the questions would be, are we on site? Let's really look at the data. Let's look at charts. Let's look at these different things. And that's not something that's easily done to get a score on from the desktop perspective. Okay. But that's a great question.
I was surprised from your revenue cycle that you graded it as well. I would almost guarantee if you walk out in the community, the first thing they're saying is the building is terrible.
A lot of those things
maybe
are
this is industrial
bill.
Well, no, it's the timing, you know, that's...
Part of that may be the communication issue. And we did talk about, you know, how you communicate the billing to the patients. And that is one of those things that you'll see kind of embedded in our recommendations. That there may be some suggestions that we have that we know has worked well in other hospitals. I know the PR committee is beginning to look at that. And so there are some things that I think we can assist with. But from a full process standpoint, the hospital is doing pretty well. Right? That is just so frequently one of those PR issues for a number of reasons. I mean, especially if somebody gets what's not really a bill, but sort of looks like a bill, and what's the communication that's there.
And the industry is part of it, and that's what I was going to say. Part of it.
Absolutely.
Because a year, 18 months later, the insurance company finally pays, and then they get their final bill, and they say, that was 2 years ago. What are y'all doing billing me now?
Yeah, exactly. Yeah, the whole that aspect of the revenue cycle is always challenging. So you get, you know, if you get your EOB, you know, from it, you're trying to understand what that means. We got to go back and put the benefits out to understand what that means, and so that piece is always complicated. But if we look at it from A to Z, that being the Z piece of it, Cindy mentioned it scores very well. So that's a great place to be. Yes, ma'am.
Did you look at it from the exact communications or just in a timely manner?
No, we looked more at a timely manner.
So you didn't look at the exact patient communications?
No, and again, you'll see in our recommendations, that is an area that we recommend some on-site visit with, and that would be part of it. You know, how are you communicating, when are you communicating, do you need to communicate that soon, etc. And so you'll see that in the recommendations.
And we, Angie's committee is PR, and she's pretty sensitive to that issue as a result of that.
We've already addressed that, we've begun to address it.
Yeah, but I don't, even though we've begun, I don't know.
We haven't, yeah.
You know.
No, we've
We
only
might not
just
scratch the
begun.
surface, yeah.
Yeah, we've only just begun on that, so it was interesting to me to hear how you looked at the data. So you basically just looked at a timeline of, and not what I would call the soft side of how you approach.
We did not look at the actual letters that go out.
Okay.
There seems to be some evidence that the rental doctors we have literally go straight to collection. They may send you an invoice one month, and the next month they turn it over to collection, which is, in the ER, I mean, that's what I'm talking about, the ER, not a bunch out of Oklahoma or wherever they do it. Second month, I've seen several examples, you'll get a collection notice, and then we turn it over to collection.
But you know, I know from other sources in other hospitals, I think this billing issue is probably, I think if we were to sit in on somebody else's board that went through the same process, I think billing is going to be a topic, unfortunately, that's going to be talked about in A to Z in hospitals. Am I wrong on that?
You're absolutely right. Nobody likes
That's
to get a
probably the
bill.
touchiest.
Yeah, nobody likes to get a bill. And that's the hard thing about healthcare is that you have to bill for it. And there's no easy way to do that, but you have to have a process in place to drop that bill. If not, it's communication. There's some things that you can do before the patient even leaves that can help that processing. So there's some scripting elements, different ways. There's different ways to write the letter. For example, in the ER guys, it's really not collections, it's early out. So it's not a collection. It's portable. It's a different process. They outsource that cash avenue of it. So there's tactics that they use that aren't very friendly, et cetera. So all those things come into play. Every hospital is challenged by that. Even some of our own facilities, we're challenged by that as well. That's just the complicated aspect of healthcare.
And then the relationship between that and the insurance company. On the coding, if it's not coded precisely right, the satisfaction of the insurance company, the satisfaction of the doctor, it comes back and back. And that's partly our responsibility, and then to some degree, it may be insurance, patient, I don't know. You know, how that
Now, those kinds of statistics we looked at, and you guys are doing really well in terms of timely billing, in terms of what time it is that you turn over to an outside agency. You were functioning really, really well in those processes. Okay? So if there's some, that's why I say I think it's perhaps more of the communication issues.
That's what we have found since when we opened up with the community for feedback. We have found each one of us have reported being approached more from the communication side of it. It's more of an emotional thing.
But it's something you've got to address.
Exactly, yeah.
Just
But
because it's
there
an
has to be a
industry
way.
issue,
No.
you're not going to have
No, no, no.
satisfaction in the community without we address it.
Exactly, and that's what we have focused
And
on
whether
trying
it's
to
communication.
address the soft side of it.
They're not worried about the industry, they're worried about what they get.
Yeah, that's right. But I mean, yeah, well, it's just saying, you know, it's kind of like I used to tell my service advisor, the people at least think they got a problem with their car, they wouldn't be in there.
Right.
Okay? And, you know, treat them that way. They at least
Yeah.
think they've got a problem.